to quickly rule out that this is not the clinical condition that's going on. As mentioned, tall, thin, more common in males than females. Patients with underlying lung disease, COPD, TB, collagen vascular disease, asthma, cystic fibrosis. Obviously, we can cause this, going to put a central line in, or if we're doing a procedure, we're doing a thoracentesis, taking some fluid out of somebody's lung, we can cause a pneumothorax. Obviously, trauma can cause this. Catamenial, there are certain people that will have endometriosis on their pleura or on lung tissue, and then as a consequence of hormonal changes, that can actually cause a spontaneous pneumothorax. So if you had a female who had pleuritic chest pain in and around the time of her menstrual cycle, and she had a history of endometriosis, you need to consider that that could be the cause of it. Okay, so in the guy that we had, the first one, what do you think we need to do? Do we need to suddenly decompress that? Do we need to do a chest tube on that person? Or is this somebody that we could give oxygen? I think he was, besides short of breath, I think his vital signs were normal. So is this somebody you want to stick a needle in right away? What's your name?
Augie?
Augie?
Yeah.
You want to stick a needle in this guy, Augie? You come running in there to be the rescuer?
Yeah, I'd flip a coin. But I'm gonna say no. I'm gonna say no. We're not sticking a needle in.
Yeah, I mean, when somebody's pretty stable, you got time. You got time to think. There are certain times you don't have time to think and you just need to act, right? Like that first one, or that x-ray where the lung was totally collapsed. You need to do something right away, right? Otherwise that person's gonna decompensate and die right in front of you. That's why one of the things, and maybe we'll get into this on the trauma day, when you have somebody with a traumatic injury to the chest, the first thing they do when they, if you have absent breath sounds on both sides, you put bilateral chest tubes in. You don't even wait for an x-ray. You do that right away. And this guy, he was pretty comfortable with regard to his vital signs, some shortness of breath, so we got time. So there's two options if you want to decompress a pneumothorax. You can either do a small 14 gauge needle. Thanks. Let's see if that works. Yeah, thank you, much better. You can do a small needle into the chest. You'll hear a whoosh of air and the patient will suddenly feel better. It's not definitive procedure for a large pneumothorax, but it'll buy you time if they need to have a chest tube, a thoracentesis put in. There are two places that you can do this. Left anterior second intercostal space, so mid-clavicular line, 2 rib spaces down. You put a 14 gauge needle in there, you take the catheter off, and you'll hear a little whoosh of air. The patient will suddenly feel better. You can also do it lateral here, anterior axillary line. You can do it in the 4th or the 5th intercostal space. And that's what we might do if you were ever in a situation. Let's say you were leading a wilderness expedition and somebody had a fall. They had crepitus. Crepitus is air in the soft tissue, and they were short of breath, and you were fairly certain they had a pneumothorax. You're out in the wilderness. You don't have an x-ray machine there. You listen. You hear decreased breath sounds. Having a little 14 gauge needle, you can save somebody's life with that until you can get definitive help. Small bore tube thoracostomy. This is somebody you reserve for trauma or has a lot of blood in the chest or fluid. That's a thoracentesis or a chest tube. And that's something that usually is going to be in there for several days until that tear or that leak heals up. Or in this particular case, you got some time. You throw the person on some oxygen. You evaluate whether that's helping with his shortness of breath. Remember, it was a relatively small, and that might be somebody that you would observe in an observation unit and repeat the x-ray in 12 hours and see if it's progressing or if it's lessening. And oftentimes you can avoid a procedure on somebody like this. So this might be somebody that young, healthy, otherwise normal vital signs, even though they're a little symptomatic with shortness of breath, you might put them in an observation unit, watch them for 12, 24 hours, get 1 or 2 x-rays, and if they're doing well, you can observe them as an outpatient, have them come back in 1 or 2 days for a follow-up x-ray. And most of the time, this air gets reabsorbed and resolves. Oh, here you go. Smoking cannabis is a risk factor for developing a pneumothorax. True or false?
True.
True. A lot of that is, there's another condition you can get when you have a forced Valsalva maneuver over a closed glottis. So somebody who's smoking and they cough against the closed glottis, you can actually develop a small tear, and you can develop a air in the mediastinum. It's called pneumomediastinum. When you listen to them, you hear a little crunch across the mediastinum. They typically resolve, and you don't see it as a pneumothorax, but you see a little outline of the heart with a little bit of air in the mediastinum. So that could be a very similar presentation to this, spontaneous, but it's more midline, and they get a chest pain that worsens with leaning forward. They'll get chest pain that's not particularly paralytic, it's there continuously. That's air in the mediastinum. We talked about some of the risk factors. Marfan, tall, thin, usually associated with connective tissue disease, also at risk for what other condition? Marfan syndrome.
Aortic dissection.
Pardon me?
Aortic dissection.
Aortic dissection, yeah. You get somebody tall, thin come in with chest pain radiating to the back, searing kind of pain, tearing pain. You better be thinking a dissection pretty quick. Okay, we talked about that. All right, just because of time, I'm going to read this. 47-year-old guy presents with sudden onset of a tear. Oh, there we go. Tearing chest pain radiating to his back. That's the typical presentation for an aortic dissection. And I've had a number of these over the years. And actually, I had a terrible one, a 43-year-old guy, where we missed the diagnosis initially, and then we were able to eventually get the diagnosis. But he didn't exactly present like this, but it can be an elusive diagnosis, and you always need to consider aortic dissection in your differential diagnosis. So sudden onset of a tearing pain, we'll go to his chest x-ray in a second. Blood pressure is elevated, 190 over 110. Heart rate essentially normal. Respiratory rate 18. So aortic dissections are not associated with shortness of breath per se. Oxygen level's good. Okay, so remember that last x-ray? Is it Daniel?
Yep.
Daniel. Well, that last x-ray that Daniel showed, this looks quite different. Would you agree?
Yes.
It's a portable x-ray, and sometimes with portable x-rays, you get some magnification. These are external monitors on the person, their cardiac monitors. But certainly, that heart looks bigger, and specifically, the mediastinum looks wider. So when you have an aortic dissection, one of the findings is widening of the mediastinum. So if you have a person who has the symptoms that we just talked about, has a portable x-ray that looks like that, you should be setting them up for a definitive test, and probably on the phone with either another center if you have to transfer them, or with your thoracic surgeon sooner rather than later. You can see here, pretty much lung markings going all the way out to the side. You don't see that little apical cap there. The big thing on this is relative cardiac enlargement and that wide mediastinum. So this is a person who's going to get a CT of the chest. They basically inject the dye as they're going onto the CT table, and then they run rapid sequence cuts. In this particular case, I apologize, it's probably hard to see from the back. This is the aorta, that circular structure there. This is the actual lumen of the aorta. This is a false lumen, so this is the intimal flap or the tear. This is all clot in here, and this is blood. That's likely going to extend, and when somebody has an aortic dissection involving the root of the aorta, what other structures at risk? Did you guys do anatomy yet? Yeah, so what are the things that are coming off the aortic arch, really? supplying your brain, right? Supplying your brain. So the carotids. Also, the coronary arteries come off the root of the aorta, right? So sometimes these will present with an ST elevation MI because they dissect right into their coronary artery and they restrict the flow through the coronary artery. Also, if they dissect retrograde back towards the heart, so again, high pressure, the heart's pushing out blood, high pressure. That guy's systolic was 190, remember? That's a lot of force on the lining of the aorta. If they dissect retrograde back towards the heart, they can cause blood into the pericardial sac, which can lead to pericardial tamponade. That was what the guy had that I had. He had like some atypical symptoms. He was feeling better, but then his blood pressure dropped. He had muffled heart sounds. His EKG changed, and he was developing a pericardial tamponade. Diagnosed by echocardiogram, went up to surgery. We classify aortic dissections. There's a Stanford classification. That's either a type A or B. Easy to remember. A involves the ascending aorta and everything else. B involves only the descending. Descending is distal to the innominate artery. That's right there. So this is descending, ascending involving the arch. Patients with Stanford type B can sometimes just be managed medically with blood pressure control, slowing their heart rate, lowering their blood pressure. Ultimately, they need some type of definitive. If they're an older person with lots and lots of surgical risk factors, sometimes they just manage them medically, and these things usually will clot off. People with type A need to have surgery, otherwise they die. It's got like an 85% mortality in the first 12 to 24 hours. So management of this initially, if you take care of them in an emergency setting, is you want to get their blood pressure down. You want to get their blood pressure down. This guy was 190 over 110. So you actually want to get their systolic, I don't want to say controlled hypotension, but you want to get their systolic well below 120, maybe as low as 100. Now you can do that in a couple of different ways. Beta blockers lower blood pressure. Beta blockers lower heart rate. Nitroprusside will lower your blood pressure, doesn't do anything for your heart rate. So if you're going to lower their blood pressure with something like nitroprusside or another potent blood pressure medication, you better first control their heart rate. Because if I lower your blood pressure, what does the heart reflexively do? Increase, right? It wants to go to reflex tachycardia because of lower blood pressure. So in this case, first thing you do is you control the heart rate. You don't want them to become tachycardic. That increases that shear pressure. So starting with a beta blocker and then bringing them down with some nitroprusside. The other thing you can do is you can do a combined alpha and beta blocker, something called labetalol or normidine. That's combined beta and alpha. You can do that, and that's probably what I would do first, because the nitroprusside takes a while to get set up. It has to be protected from the light. The nurses will have to titrate it very closely. Whereas labetalol, you can kind of give it in pushes, 10, 20 milligrams every 5 minutes, and control it pretty easily that way. And then in the meanwhile, with a type A, you want to get definitive treatment done, and that's contacting your chest surgeon. There's another classification, won't spend too much time, it's called the DeBakey classification. DeBakey was a heart surgeon in Texas Heart. He was one of the guys who did the first open heart transplant, or the heart transplant. He was kind of the grandfather of open heart surgery. So it was named after him. There's type 1, 2, and 3. Type 1 is the ascending aorta arch and descending. So that's the same as the Stanford class A. And then type 2 is just the ascending. Type 3 is descending. So there's different classification systems, and then that drives your treatment approach. So in this particular case, what do we think would be the most appropriate treatment? Would you give them diazepam, which is Valium? Yeah, I mean, what hypertensive situation would you give diazepam to? Somebody came in and got blood pressure of 200 over 120, they were up partying all night, they're bugging out, what would you give them? What were they probably toxic from? Cocaine intoxication. You don't treat them with a beta blocker because then you get unopposed alpha, and then they're actually, that can cause their blood pressure to go up. So somebody who comes in and they say, oh, I was doing cocaine all night and I got chest pain and their blood pressure's through the roof, those are the ones you gotta get calm first with some IV Valium. Because if you just give them a beta blocker, and I love beta blockers, I give them a lot in the ER, but if you give somebody with a cocaine overdose, beta blockers, you can actually make things worse. Labetalol, that's the alpha beta blocker, alpha and beta blocker. That one would probably be a good choice for this. Nitroprusside, you would not give that alone, because remember you get the reflex tachycardia with that. And phentolamine is another antihypertensive agent, but probably you would not give that alone. So those are what we call, so sympathomimetic drugs like cocaine or methamphetamine, you want to get them calm with some Valium, get them kind of chill. The nitroprusside, we said we wouldn't do that alone, you need a beta blocker. And phentolamine is an alpha blocking agent used to treat hypertension associated with a field because of excessive alpha adrenergic stimulation. Too much stuff to read there. Let's get to another case. Let's just see this one here. A 35-year-old guy presents to the ED with chest pain for 3 days. Okay. Pain slightly to his left, worse with inspiration and with certain motor activities while playing basketball, doing sports. It's dull. He feels like a stinging sensation, no shortness of breath, no other associated symptoms, normal tensive, normal heart rate, afebrile, O2 sat good, normal heart sounds, winces when leaning forward. Something with leaning forward that can, remember we talked about that pneumomediastinum or a pericarditis can sometimes be worse for leaning forward. So you got to think a little bit about that as a possibility. Pain noted with palpation over the left anterior third rib. So there's another condition called TT syndrome or costochondritis. That's a condition that's generally benign. You treat it with an anti-inflammatory, but don't jump to that diagnosis. Nobody dies of costochondritis. That's a musculoskeletal thing. People die of other things. So before you start making the diagnosis of costochondritis, make sure it's not these other things. You guys probably haven't done EKGs yet, right? You have? Yeah, so, all right, so in summary, is this fast, slow, or normal? Just by looking at it roughly.
Slow.
So, you know, there's a way to do it. Find one of these that land right on it and it's, remember, so let's say it was this one, 300, 150, 100, 75, 60. So this one is, so this is somewhere between 75 and 60. Every one of those little boxes, there's just a little numbers you can do. Or you can look at a 10-second and count how many beats are in there. You'll get good at this the more you look at it. So it's not fast. We worry about things like ST elevation for an MI. ST segment is between your QRS complex and your T wave. In a heart attack, that's going to be typically elevated or potentially depressed. In pericarditis, you might see abnormalities in the PR interval in here. So all in all, roughly speaking, this looks like a relatively normal EKG. We don't see any ST elevation. T waves are upright where they're supposed to be, normal axis, nothing particularly problematic with that. So I'd say in this particular guy, his EKG looks normal. So likely diagnosis to consider, pericarditis. Remember pericarditis, that's, you feel pain in the chest, usually worse with leaning forward. There's EKG abnormalities that you may see with that. Again, PR elevation you might see with that. Costochondritis is going to have a normal EKG. Costochondritis is inflammation of the chest wall. PE, what's the most common EKG finding in a pulmonary emboli? Most common EKG finding in a pulmonary emboli? Tachycardia. Tachycardia is the most common finding. There's some classic ones that we'll talk about in a second. Yeah, classic ones that you may see, but the most common finding is either normal or tachycardia. Xiphodynia, that's inflammation of the xiphoid process. So in acute pericarditis, usually sharp, improve with leaning forward. Actually, I think this might be a typo. Sometimes it's worsen with leaning forward. Positional changes can make pericarditis worse. Pericardial friction rub, you hear like someone who, like if you took sandpaper and you moved it back and forth, that's what you hear with, once you hear it, it's a very distinct sound. It's called a friction rub. And you'll get diffuse ST segment elevation with PR depression in a pericarditis. Costochondritis, we said it was a normal EKG. PE could present with sharp chest pain. Most common is tachycardia, which we didn't have, and xiphodynia, which is inflammation of the xiphoid process. So in this case, it was costochondritis. You treat them with anti-inflammatories, discharged home, limit activities. They're usually better in a couple of days. But again, this is a diagnosis you don't want to make willy-nilly, because a lot of people, if I push hard enough on anybody's costophrenic angles, I can cause pain, right? So just be open-minded when somebody comes in and they say, yeah, it hurts a little bit here. Just make sure that you're not missing one of these other diagnoses we talked about. Okay, 47-year-old female with a history of hypertension and diabetes, 2 risk factors right there, right? Hypertension and diabetes, presents intermittent stabbing chest pain over the last 2 days, no shortness of breath, nausea, vomiting, or diaphoresis. Remember, inferior wall MIs can just give you nausea, epigastric pain. So not everybody has classic pain of, I feel pressure on my chest, I feel like there's an elephant sitting on my chest. Not everybody presents that way. Little bit of radiation to her left arm. Remember, diabetics sometimes will have very atypical symptoms. They may not have normal, they may just come in. I had a diabetic came in, just had jaw pain. His dentist sent him in because the dentist didn't find anything wrong in his mouth, and the guy was having a jaw pain. Turned out he was having an MI. So diabetics, you got to be a little bit careful with them because they can sometimes present with atypical. It's almost like they have a neuropathy in the cardiac area that they're going to present with different symptoms. Lasts a few minutes, resolves on its own, not associated with exertion or eating. You know, exertional chest pain often can be angina. Pain or worsening with eating might be reflux or GERD or something like that. So it's important to kind of determine whether that's associated with it. Normal vital signs, a little hypertensive there, no fever, unremarkable physical exam, and we'll get to her EKG. I think we have it here. EKG in this particular one. Some abnormalities here. These are T-wave inversions. You should have upright T's in there. So this is lateral ischemia here, 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 here. So this person's probably having some type of lateral wall ischemia. Again, remember with diabetes, you got to be very careful with patients that present with some atypical symptoms. Being respectful of time, I want to do one more case with you here. Okay. Something don't look right with that EKG, right? So this out here, these are big ST elevations here. What do we call those?
STEMI.
It's a STEMI. In this particular one, we call those tombstones because they look a little bit like tombstones. These are the ones that somebody come in, big anterior wall MI, big anterior wall MI. Actually, there's a little bit of lateral. 1 and L are lateral leads. 1 and L are lateral leads. So there's a little bit of ST elevation here, a little bit here, pretty much across the whole anterior and lateral. So this is a big anterolateral MI. This is one that you don't have a lot of time on this, because the longer that this person has this occlusion, the more heart muscle they're gonna lose. Tremendous risk for arrhythmias and, ventricular fibrillation. So this is somebody that you wanna get treated pretty much right away. So a 65-year-old person, substernal chest pain, heavy pressure, about an hour, hypertensive, normal heart rate. He's got an oxygen level of 98%. Anywhere 90 to 100 is normal range. 92 to 100 is essentially normal. What is troponin? Have you guys done any of that stuff yet? Yeah, so troponin is a biomarker. There's brain troponin, and there's heart troponin, and there's muscle troponin. Troponin I is from the heart. And you can see that that's elevated. I don't know what normal levels are for this, but generally under 10 is essentially normal. So this is 8 times the normal limit. So he's already starting to spill troponin into his bloodstream. What I will tell you is this: if you have this EKG, you should be making your decision and not be waiting for the results of a troponin level. You should be getting that troponin level after the person left your department and is up in the catheterization lab. So typical chest pain associated with a myocardial infarction.